Welcome, everyone. Thank you for coming to Paging Dr. Ram, the live Google Plus Hangout and Q&A. Today we're going to talk about part 2 of our colic series. So today's going to be focused more on what happens if your horse has a more severe colic than what can be successfully treated at home or in the field, and what is actually involved, what's involved with the surgery and all of that. So. And then we'll open it up for questions from all of you. And you can submit questions anytime just by typing them in below at the bottom of the screen, or you can also email questions to this address, cvmbs-socialmedia@colostate.edu. So I begin by introducing myself and then my colleague, who is also going to be helping out tonight. My name is Diana Hassel, and I am one of the equine emergency and critical care clinicians at CSU. My background is I graduated from vet school at the University of California, Davis back in 1993, and have mostly been specializing in the area of colic since. I did a surgical internship in Washington and then went back to UC Davis, did an equine surgical residency, and became board certified in equine surgery in '98, and then went on to pursue some advanced research degrees and a PhD in equine gastrointestinal physiology. Then I finally came to Colorado State University, which I love. I love being here and working here, and went ahead and furthered my education a little with critical care. Equine critical care fellowship, so obtaining a second board certification. So I'm really very specialized in this area of colic and other types of emergencies, especially surgical emergencies, and that's my background. I'd like to also introduce my other half for the emergency and critical care service here, Dr. Eileen Hackett. So I will put her on to let her give you an introduction of herself.
Thank you, Diana. I'm also thrilled to be here tonight with you all, and hoping that this will be a productive discussion on surgical colic and how it'll impact you. Just give you more information about it. As Diana said, I also work at the Colorado State University, and I've been here for 12 years in the emergency surgery and critical care department. Back to you, Diana.
All right, thanks. So at this point, I think we'll go ahead and get started with a little presentation I put together for you guys on what happens when your horse comes to CSU with some more serious colic. So give me 1 second to transfer over the presentation. Okay, so colic surgery in the horse, a look inside. So just to start out with, as you guys probably know, if you know a little bit about colic in horses, its basic definition is colic just means abdominal pain. So it can be from any source, but 99% of the time it's from a problem with the gastrointestinal tract. So that's the majority of colics. But you can get it from other places like the kidneys or the bladder if it gets obstructed, or the liver and those types of things. But most of the time we're talking about intestinal pain from the gut with colic. And it is the #1 killer of horses. It's a major problem that we deal with. And so it's important that you guys, when you encounter it with any of your horses, that you get on top of it quickly and take good care of your horse so that you'll have a good outcome. And it does affect all breeds in all locations. It doesn't discriminate against one versus another. So what happens when a horse with colic arrives at a referral hospital like CSU? The first thing that we'll typically do is get a good physical examination. So we'll ask you lots of questions as well. Get a good history, find out a little bit about your horse and where it's been, and then we'll look closely at the horse itself. We'll assess its attitude, how painful the horse is. We'll look at the general physical condition. So was there past severe pain? Sometimes they'll really beat themselves up. They'll actually scrape their skin up, and if they had a real severe colic episode before. And that really gives us a clue as to what type of condition might be going on. We'll look to see if they look distended in the abdomen or bloated, and sometimes we'll ask you as well as the owner, because you have the best idea of exactly what your horse looks like as far as their body shape. We'll assess their heart rate. So a normal horse's heart rate, we like to see it 40 or below, usually 32 to 40 in most situations, and so we'll assess that, and that's an important indicator of severity of disease or severity of pain. We'll also measure the respiratory rate. Sometimes that'll go up when they're in pain. Then we'll look closely at their mucous membranes. We'll check their jugular vein, like here, for how well it fills up with blood, how quickly. So horses that are very sick with severe colic may lose a lot of their blood volume. It goes away from their blood's vasculature and into other areas of the body like the gut, and that'll be compromised, as well as their mucous membranes will be pale, and they also can be reddened when they have certain conditions. So those are the things we're looking for. We also measure their capillary refill time by pressing on their gums and just looking at how long it takes for that the blanching to return to normal. So the other thing we'll look at, because horses are so prone to getting laminitis or foundering, which probably many of you heard of, we check their digital pulses, and with severe colics, that's a big problem that we'll see. So we'll monitor that really closely. We'll check their temperature. So most colics are going to have a pretty normal temperature, actually, but if it's abnormal, that gives us a clue as to what type of disease process might be going on. We measure their gut sounds in all 4 quadrants of their abdomen, so on the upper and lower quadrants on either side, sometimes down below as well if you're looking for evidence of sand in the colon. And then we do a rectal palpation where we stick our arm, but probably not in this little guy, but in the regular size horse, we'll stick our arm in the rectum and feel for abnormal findings, and that's really useful in terms of getting a diagnosis. Once we've done a thorough physical exam, we'll go on to do some diagnostics. So if your horse has been colicking for a period of time, which is usually the case when they send them to CSU, we'll often want to check blood work. So we'll look at what we call a CBC, or complete blood count, and that tells us, 1, how hydrated they are, 2, if they've lost a lot of protein in their blood, 3, if they have an inflammatory process or an infection going on. It's pretty useful information for us to start with. The chemistry panel is also really helpful because that gives us an assessment of all the electrolytes in the blood. It tells us if the muscles are injured from the colic episode. It tells us if the kidneys are in good shape. The kidneys will get damaged pretty readily with severe colics when they get dehydrated. So, and then they receive drugs like Banamine. In a state of dehydration, they can really hurt their kidneys. So we check that. The liver function is also checked, as well as a number of other parameters. It's a pretty comprehensive panel to give us a great idea of what might be going on and how severe is this disease process. We'll also pass a tube. So some people wonder why we pass a tube, and the main reason is horses don't have the ability to vomit like a dog or a person or most other species. So we need to pass a tube down into the stomach. If the stomach is really, really full, or fluid is backing up from the small intestine into the stomach, and we don't let the pressure out, it can actually burst and cause them to die from that. So the first reason we check with a tube is to make sure their stomach is not overly full and they don't have an excessive amount of pressure in there. The next reason is it's diagnostic, so it gives us an idea of what type of process might be going on. Are we dealing with a stomach problem? Are we dealing with a small intestine problem? Or is it somewhere else? And the nasogastric tube is a great way to treat these horses most of the time. So a lot of the things we see are impaction colics, where they get hard feed material stuck in their intestinal tract somewhere. And so a key part of the treatment is actually giving them oral fluids, usually balanced electrolyte solution, but you can also do mineral oil or just water to help with treatment. So there's a lot of reasons we pass the tube, and those are the three big ones. The other thing that we'll do if your horse's colic has been going on for any period of time, or if we're concerned about a pretty serious problem, we will go ahead and try to collect a fluid sample from their abdomen. So this is fluid that normally would be in the belly that surrounds the intestine. Okay, so it basically has kind of a lubricating function normally, and it has normal values that we look at. In colics, these values tend to change with increasing severity. So the first thing we'll see is an increased volume of fluid. The next thing we'll see is the protein in the fluid goes up, and then lastly, the white blood cell count can go up if they get an infection going on. And this is an example of what we do. We just do a local block so they don't feel us stabbing them with a small blade, and then we put in a little cannula, pop it into their belly to try and get a sample. And this is a very abnormal looking sample. This is from a horse with a strangulated intestinal problem, and so you can see that fluid's very red, but normally it should be nice and clear and yellow in the normal horse or in a horse with a non-strangulating problem. That gives us a lot of information as to whether or not this horse might need surgery or not. Sometimes it's obvious. If they're so painful we can't control the pain, we just know they need to go to surgery. So here's an example of some normalish looking fluid. It's a little extra yellow because when they go off feed, they get an increased yellow color in their body, in the blood. This is an example of a really abnormal hemorrhagic fluid, and this is the spun down part from a horse that's actually ruptured its stomach. So it has this kind of greenish, brownish tinge to it, which is something we never like to see. That's a bad thing to see with a belly tap. Another really, really important tool that we use in almost every colic that comes in the door at CSU is abdominal ultrasound, because we can diagnose so many things with abdominal ultrasound that we can't by other means, because it just gives us a peek into the abdomen, a view of what's going on under the skin when we can't, especially in areas that we can't reach. And there's really classic abnormalities that we look for with the abdominal ultrasound that are really helpful to give you a more definitive diagnosis, so we can give you guys the best prognosis that we know of for a given condition, and also determine if surgery is the best way to attack it, or if this is something we can treat with just some fluids and medical therapy. And lastly, on occasion, we'll do x-rays of the abdomen. The two big things we look for x-rays with x-rays in the abdomen of the adult horse is sand, because it's really dense, so it'll show up as white on the abdominal x-ray. And the other thing is called interlist, which I'll show you some pictures of later, which are stones that form in their intestinal tract. We don't see lots of those here in Colorado, but we do see them, so we have to always keep our eye out for them in some of our colic cases. And that's what we'll use x-rays for. And they're also really useful for the little guys, like the miniatures and the foals, where we can't palpate them. They're small enough we can actually get pretty good detail with an x-ray, as opposed to a big horse where you just get this white out and just can only detect super dense objects. All right, so once we do all those things, we use all that information we've gained to decide whether or not surgery is indicated. And if we figure out that it is, and really the most important thing is response to analgesics or pain-relieving drugs. If they stop responding to those and they keep being painful, typically we'll need to take them to surgery. So the next step is inducing anesthesia. First, we need to make sure they're stabilized. So oftentimes we need to give them IV fluids before we induce them if they're really unstable because of the disease. We'll also pre-medicate them with antibiotics, and we'll give them pain relief with Banamine so that when they wake up, they have some on board and it can be a little less painful process for them. Often we'll place a nasogastric tube because we don't want their stomach really big and then to drop them and have that to burst when they get induced. So we make sure that we don't have increased pressure there. And we also like to make sure they're updated on their tetanus status. So this because whenever you make any type of cut into a horse, you want to make sure they're current with tetanus. And as far as anesthesia, we have a great anesthesia team at CSU in terms of what they look at to make sure your horse is stable under anesthesia and is getting as much support as they need to stay alive during a very critical time for them when they have severe colic. So they do lots of IV fluids, they monitor their arterial blood pressure, they give them drugs that provide blood pressure support in addition to the fluids. They measure their heart rate, their rhythm, and the electrical activity of the heart. They monitor closely their depth of anesthesia. You don't want to give them too much anesthesia, but enough that they don't feel anything and they stay asleep for the procedure. They measure oxygen and other blood gases in the blood on a regular basis to make sure they're oxygenating them very well for the tissues. They measure electrolytes to make sure those are okay, and hydration and blood protein losses as well. And all those things are monitored and corrected as best they can during anesthesia. So here's a few pictures. So this is just the anesthetic unit with the ventilator. So inside here is a big bag that's compressed and opens to put air, mostly oxygen, and a little anesthetic gas into the lungs. And it's put through this tube and then again through an endotracheal tube, which is put all the way down into their trachea when they're first induced. This is just some of the monitoring equipment. Here's the ECG here, and then they're doing direct pressure monitoring of the blood pressure. Here as well, they measure systolic, diastolic, and mean blood pressure throughout this whole time, as well as a number of other things. And this is just an example of some of the continuous rate infusion units, so fluid administration and drugs at very specific rates to make sure they're stable under anesthesia. And here is a little video going through some of, this is a horse's abdomen open with the intestine out. This is a horse with what we call a small colon impaction. And so the ventilator's on, you can hear it, and this is an direct arterial line to measure the blood pressure directly. And then we have, this is the ECG unit, and also measures all your blood pressures throughout the whole time to make sure that blood pressure is maintained. Here's some of the CRI units that give drugs to improve blood pressure, and here's the ventilator unit and the anesthetic administration. You can see the bag compress as they breathe. I think they'll show you. There we go. And that goes down to the endotracheal tube, which is down in their trachea. So when we do surgery on your horse, almost always what we're going to do, because it gives us the best access, is what we call a ventral midline incision, and that is this one right down the middle, right in front of the belly button. And that gives us great access, and it's a nice strong closure with the linea alba there. But there are other places you could go into the abdomen, such as paramedian, which is on the side. So if for some reason we can't have access to this area from a previous surgery or a problem there, we can go next to it. There's laparoscopic techniques where we actually put a scope in their abdomen and can drive around and look at things. You're a little more limited with the handling component, but you can go ahead and open them up with a flank and maybe do some manipulations if you find something laparoscopically. And there's periinguinal approaches as well, but not for major colic surgeries typically. So what can we visualize in surgery? This is just a little picture of what we can actually bring out of the belly through a ventral midline incision. So this is the stomach right here, and this is the beginning of the small intestine called the duodenum. And then this is the most of the small intestine, which is the jejunum, and then the last little part's called the ileum. So the white part, we can pull all that out of the abdomen and actually see it. So most of the jejunum we can bring out and see, or we could see it. The yellow part is what you can see but not bring out of the belly. The red part is what you can only feel and you can't visualize. So you could see if you have a major problem where you need to remove a section in the red part, that could really pose a big problem for us and may not be something we're able to fix. Fortunately, the majority of problems are in areas that we can exteriorize or at the minimum visualize. So here's stomach, duodenum, jejunum, ileum. So this is about 80 feet worth of small intestine right here. And then we have this structure called the cecum, which is analogous to our appendix, but it's about 3 feet long in the horse, and they ferment feed in there and get energy from it. This is the large or ascending colon right here. This is pelvic flexure, where sometimes horses will get impactions, and this is still large colon. Here's the right dorsal colon. Horses will get impactions there as well, and you can't feel those. So often that's where they are when they're not felt by your veterinarian. And then this is called the transverse colon, and then the descending or small colon, and the rectum, and this is where we're palpating before surgery. So once we get your horse anesthetized, we position them on their back using a hoist and a little bit of manpower, and we clip their whole belly area just like this, and clean it all up, and then do a nice sterile prep over the whole area, with the most important area being right in the middle. We can see we put bags on all their feet so we don't have any debris flying around in the surgical area. Oops. And then what we do is we apply what we call a colic drape. So there's a sticky drape on there, and then this specialized drape for colic surgery, which has little pockets that are waterproof, where we could put intestine in so it doesn't fall down on the floor while we're working on another part of the intestine. This is the front feet folded up here, and the back feet are back here. And then we go ahead and make the incision. So we just spread the skin, go first through the skin, sub-Q layers, and then we'll go through the body wall or linea alba after that using a scalpel blade. And then from there we will go ahead and do an exploratory. So this is an example of a pretty happy, normal looking cecum. So the tip is right here. You can't see the end of it, but that's the end. This is some small intestine. And this is also small intestine, but it has fluid in it, and this part's empty, so it can really get dilated and big when it gets full of fluid or gas. And here's the large colon coming out through here. This is the ventral colon and the dorsal colon. You can see it's smoother, and that goes out to the pelvic flexure, which is right about out here, sitting on a special tray we call a colon tray, so we can empty the contents if we need to, if there's a big impaction in there. And here's another view of an empty, nice, normal-looking colon. Here's the pelvic flexure at the end, and just so it's nice and empty compared to that last one. This is an example of a really badly twisted intestine or a large colon. So this is called the colon volvulus or colon torsion, and it's a really common cause of surgical colic. And if this occurs in such a manner that it looks this bad, and it occurs way down at the bottom of the abdomen where we can't access all the way down, sometimes the best option in these horses is euthanasia. But the earlier you can get them to surgery, the less likely they're going to be all purple like this, and they'll still be in good shape, and hopefully you'll be able to just untwist it, which we do with the vast majority of them, and they end up doing okay. And then here's an example of what we call pelvic flexure anerotomy, where we make a hole in the pelvic flexure in this area far away from the abdominal incision, so it's nice and safe, and because we have fecal material coming out of here, and we don't want that contaminating our incision. And then we have special hoses to keep everything away from the incisional area, and we can flush out impactions and intralis and all sorts of things like that. So I told you I'd show you some intralis. These are those stones I was telling you about. The horses can form these in their intestinal tract. These are two big gigantic stones that formed in a horse. And this is what it looks like when you take them out. They're they're rock hard and pretty heavy usually, but they can vary in how solid they are. And here's an example of a lumpier looking one that was in the small colon, or further down than the other ones I showed you, more like a baseball size. And here's a video of taking one out. So this is the large intestine, and we've got it all draped. So the incision's pretty close, but we have special draping to isolate this from the abdominal cavity. And we pop out the enterolith like a baby. And this is a view from the other side with that small colon. You have these littler ones. These actually cause a much bigger problem for the horse because they really completely plug them up, and if you don't identify these early enough, they will rupture the intestine, and your horse can die from that pretty readily. Here's an example of a colon that was twisted kind of halfway down, and this is all still nice and healthy up here. So this is a perfect candidate to cut it off here and make a new opening between this side and this side. So that's what was done here. And this horse did great, just had a little colon resection and just missing a little bit of his intestine there. And he did just fine with that. Here's an example of a small intestinal problem where this is normal. So this is the normal vessels, and this is called the mesentery. So all the vessels live in the mesentery. And this is a mare that had foaled and got her mesentery injured somehow by the foal, probably kicking in the abdomen, and that compromised some of the blood supply to the intestine there. So I had to remove that section. Here's what we commonly see in the older horse, which is completely strangulated, really dead-looking sections of small intestine by a structure called a strangulating lipoma, which is just a little fatty tumor on a stalk that can wrap around the mesentery and cut off the blood supply to a segment of intestine. And we just have to go in, cut that segment out, and then reattach the two ends so that they can function again. And here's another example of a way you can attach two ends once you've removed all the dead stuff, and you can close these ends, and then you can actually hook them up side by side like that and make a hole in between them with a special stapling instrument, and down the road they actually look pretty normal. They remodel on their own. So once we've fixed everything up, we put all the intestine back in the correct location, and then we go ahead and do an abdominal closure. So usually through this linea alba, and a simple continuous pattern has been shown to be the most effective for as far as strength and distributing the strength across the whole incision. So that's the technique we'll typically use. So here's a summary of the whole thing. So you start out with the horse getting put on its back, getting prepped, and then we do a full draping procedure to keep everything sterile in the abdomen. We have all our gowns and gloves and special sleeves on to keep everything impermeable from water. So here we're just doing what we call quarter drapes, and then an impermeable smooth drape over the incision as well. Do the incision, go through the abdomen into the peritoneal cavity where all the gut lives, and then we do our explore, figure out what's going on, and we fix it. And find out what it is and put things back in their right location, empty things if needed. And this is the small colon here, and this is large intestine that is being pulled out. This is another volvulus. It's really slippery and thick because it's got a little edema in it from the vein being collapsed a little bit. It was obviously still in good condition in terms of not being dead like that purple one I showed you earlier. And then we can pull the colon out if it's really full of it, lots of ingesta. We could put it on the colon tray, make an incision here, and empty the contents some so the horse doesn't have to deal with a big impaction after we've woken him up from surgery, and especially if that's the primary problem. In this case, it's a volvulus. So here's making the enterotomy incision. Sometimes we have to do this even before we untwist the colon. because it's too heavy, and if it's damaged, it'd be easy to tear the colon, which could be fatal. So we empty it first so that it's lighter weight, and then we can fix it much more safely. And so that's what happens in surgery. The bulk of the work then occurs afterward, the post-operative care. So we have a setup here. You can see these are all our cameras. Every horse in every stall is under 24-hour surveillance. I could look at any of my patients in the middle of the night if I felt like it and see what they're doing and watch them live. But for 24/7, we measure things like some of their blood work. So are they staying hydrated? Are they losing protein, PCV and total protein? We can measure blood gas and electrolytes, blood glucose, creatinine, lactate. We give them lots of fluid support with electrolytes. They're on antibiotics for a period of time, and analgesics as needed to keep them comfortable. So we like to not make sure they're not in pain, and other anti-inflammatories. And that pretty much sums up what we do with the horses. If you're interested in learning more about some of the different conditions of the intestinal tract in the horse, this is a CD that kind of animates all the different potential abnormalities horses can get with their intestinal tract. They weren't designed very well, unfortunately. So lots of different things can go wrong with a horse's intestine. But this is a nice little setup to understand it more if you want to go there and look more into it. And that is all I have. At this point, I will like to open the floor for questions. I think we have some already, but I'm going to try and revert back to the webinar. Give me 1 second. All right, so let's start with some questions. Hope you guys enjoyed the talk, and I think we have some questions to start with already. All right, so we have a very surgical specific question from Chris Ryan that I'll start with. Is it better to remove all the intestines at once or to pull out a small section of intestine one at a time during surgery? I've seen it done both ways, but would like to know your thoughts on which way is safer. Want me to tackle that one, Dr. Hackett? Okay. Okay, so it really depends on the condition that you're starting with. Oftentimes we'll go into surgery knowing exactly what the problem is, and I like to typically have one section out at a time, ideally. Sometimes you don't have that. That's not under your control because there's so much distension of intestine. Like last night, I was up all night doing colic surgery on a horse that as soon as we opened the abdomen, all the small intestine came billowing out, yet he had a large intestine problem primarily. So we had everything out. He had a big adhesion of his intestine to the body wall, so everything had to be out in that case. But ideally, if you don't have to do that, I like to do one section at a time, take care of my primary problem first, and then we do a full explore. We make sure we look at all those main parts of the intestine so we don't miss anything, like leave behind some lipoma that's going to cause a problem 5 years from now. So that's generally how I approach it. So I hope that answered your question. Move on to another one here. All right, we got a question from Jackson. Can I watch my horse have surgery? I'm going to send this one over to Dr. Hackett to answer that one.
Many places that perform colic surgery will have a setup where you can watch a horse have surgery. Either a window built into the wall where you can just look right through the window and see your horse roll into the room and see all the preparation and surgical treatment, or potentially, as we have in our hospital, a closed feed video system where you can watch the entire procedure. And I think also many times, in addition to watching, we like to come out and just let you know what's happening, give you lots of updates, and especially if there's any major decisions, if we find a severe lesion or we have a question about treatment options, then we can help facilitate that by having you watch and then also speaking with you at the same time. Good question.
All right. Next question I got is from Tom. How much does colic surgery cost? I'll tackle that one. I can mainly tell you from the perspective of CSU because I know most about that. Typical colic surgeries, they're going to really depend on what the primary lesion is. So if it's a real simple, straightforward colic surgeries, let's say the colon is out of place and we go in there and flip it around, move things around, don't even have to do an enterotomy like I showed you in the videos, and close them up, and it's fairly straightforward. Typically those will be around $4,000 to $5,000. But we have other conditions like with that dead small intestine or a really severely injured large intestine from a twist, something like that. Often those will be more like $8,000 to $10,000, and they can go up from there if the horse really has trouble and has lots of complications or develops laminitis, things like that. Of course, we do everything we can to prevent all those complications, but sometimes they still will occur. And it'll vary according to your region. So other places might cost, well, I find that our actual cost of surgery is actually pretty good here at CSU, and where they really costs accumulate is all of the post-op care, especially now with the short IV fluid shortage. That's made it even more expensive to even treat the medical colic. So typically, if we don't need to go to surgery, you're looking at between $1,000 and $2,000 for treatment of most medical colics, like significant impactions and so forth. Okay, got another question here from Sylvia. What should I do if my vet can't come out right away? Can I turf that one to you, Dr. Hackett?
Yes, ma'am. Well, Sylvia, this is a great question, and I think it's something that happens all the time. You know, you call your vet and maybe they're out on another emergency call or they're not available. A lot of times your primary vet is going to be the best first call, and they can help you on the phone and say if they can't get there right away what the best course of action would be. And if they're simply not available, or if they tell you that it sounds like a bad colic, then at that point is when you'd want to think about taking your horse to a hospital that has specialists that are trained in both surgery and or critical care that can get your horse with colic treated appropriately and quickly. And potentially in that scenario, you know, the worst thing that could happen would be that you would take your horse to the hospital and take it home the next day and not need surgery. So that's always a happy moment for everyone, and certainly better safe than sorry when many of the conditions that cause severe colic are extremely time sensitive, in that the quicker you treat them, the more likely you are to have a good outcome for you and your horse.
All right, great. Thanks, Dr. Hackett. I have another great question from Chris Ryan. So his question is, I've been to 2 different vet hospitals. One used a drug after surgery to reduce the likelihood of adhesions after colic surgery and continued a lavage daily for a few days post-surgery. Another vet hospital told me this could cause bleeding problems. What's your viewpoint? Okay, I'll tell you my viewpoint. There are some conditions where a lavage system is ideal and appropriate, and mainly for me that is when there's significant peritonitis or inflammation in the peritoneal cavity before surgery or during surgery. So if there was any contamination, let's say you had to cut something out right at the incision and you're worried about some spillage of intestinal contents, that is a situation where I do like to do a lavage system and be pretty proactive about adhesion prevention. Of course, we always like to work toward adhesion prevention. I'm guessing the drug that you're thinking of is heparin, because that's the only one I could think of that would lead to potentially some bleeding issues. And actually the new generation of some of the heparins reduces the chances of that, but unfortunately it's pretty expensive to use. We often don't use that version of heparin. Often we'll use other methods to help reduce the potential for adhesions, and we rarely use drains, at least here at CSU. It's pretty expensive and it's invasive, so we only use them when we absolutely need to. So that's my opinion on it. Dr. Hackett may have others. I don't know if you do. Do you want to comment, Dr. Hackett?
Thank you. I agree. You know, I think there's still a lot of surgeons out there using heparin therapy and other therapies for adhesions, and certainly developing adhesions is something that can really impact future colic in the horse, and just how well they can use their GI tract and function after the surgery. So certainly, as Diana mentioned, you know, that we're going to use key surgical principles primarily to prevent adhesions, trying to keep the time down, trying to keep the bowel moist, trying to keep trauma to the bowel low, and a lot of times we're sort of at the mercy of the primary lesion and what's causing the problem to start with and how severe that is. So certainly lots of different therapies out there. Heparin certainly is still in use many, many places, but it rarely has been associated with serious bleeding events. So I think it's pretty safe to use it, and not too many complications for most horses.
Great, thanks, Dr. Hackett. I got another question here from Sherry. What is the follow-up recovery process like after surgery? I'll go ahead and give that one a shot. It's not as bad as you might think. It depends a little on how well the incision heals up. So we count on having a nice, uncomplicated healing of the incision, and about maybe 10% or so will get incisional infections, and that will prolong the recovery period. But typically what you're looking at, if your horse has colic surgery, we do 30 days in a stall with hand walking, 30 days turn out into a smaller paddock, and then I'll go ahead and put the horse under saddle at day 60 and up until full work by day 90. And some people like to go 90 days before putting the saddle on, but research shows that their incision is quite strong at 60 days, even stronger than at 90 days. So my contention is you can start at 60 days, and that's worked out in all the situations I've used it in. So that's typically what you're looking at if there's no complications with the incision in the post-op period. Any other comments on that one, Dr. Hackett? No. Okay. We have another question from Chris Ryan. He's full of questions. It's awesome. What type of joining of intestinal ends do you prefer to use, and why, if you have to cut some out? So there's a lot of different ways to reconnect intestine together, and I'm primarily, it depends on the section of bowel that's involved, but my favorite is just to do a classic end-to-end, where you take the two ends of bowel, remove the section, and put them back together just like the normal anatomy originally was. That's my favorite, mainly because it's closest to the original type of anatomy that the horse had, and also it's the least expensive in terms of you don't need all fancy stapling equipment to connect two ends together. You just need some suture material, and so that's why I prefer that. Those two reasons. There are certain procedures, like when you have to hook the small intestine to the cecum, like when the very end of the small intestine or the ileum is damaged beyond repair. Oftentimes I'll have to stick intestine to the cecum. In that case, I use side-to-side anastomosis, which is a little different because that's what's you're basically hooking two pieces of bowel together. They're very different. One's a big giant viscus, and one is a very small tube. So for the large colon, typically we also do end-to-end anastomoses. Oftentimes one side is a lot bigger than the other, so we'll have to cut one at an angle in order to make it relatively bigger to the other side so that we can make the two ends fit together. That's all I have. Dr. Hackett, any other comments on that one? I think I'm muted. Okay, Joyce asks, should I get health insurance for my horse? Want to try that one, Dr. Hackett?
Yeah, thanks, Diana. I think when you bring your horse into a hospital with a serious colic and you're looking at either some pretty intensive medical therapy or a surgical repair of their lesion, it can be pretty emotionally wearing, and a lot of times we're asking you to make decisions pretty quickly. I think that having your horse insured can really take some of the stress out of that decision, knowing that the insurance will have to cover whatever treatment is necessary can really take some of the pressure off. At least, a lot of these conditions are associated with some pretty significant costs, so anything you can do to make that decision easier is helpful. It's hard to see your pet that so much pain, and anything you can do to make it easier, whether it's participating in the seminar, something like we're doing tonight, where you can just get more information about the process, what is colic and what could it mean to you and your horse, as well as preparing with insurance is always a nice way to think ahead.
Great, thanks, Dr. Hackett. We got a question from Andrew. Is it okay to give Banamine to my colicky horse before having the vet come out? I have fairly strong opinions on that. I think the majority of the time you're going to be completely fine doing that. The problem is in certain situations, particularly if your horse is dehydrated, or perhaps if you give Banamine and then your vet comes out and gives more Banamine and they're a little dehydrated, you can really set them up for problems. So if your vet says to give some Banamine and monitor them, I think that's okay to consider, but just to do it on your own without having at least a assessment of exactly what the horse is doing from a veterinarian, I think that's less than ideal personally. I would rather, an alternate approach would be a dose of sedation, just kind of break the pain cycle. A lot of the sedatives like xylazine can be given in the muscle, which is pretty easy to do even for a horse owner with a little bit minimal training. So that is a little safer as far as it's not going to cause damage to the kidneys or to the intestinal tract. It's just going to kind of block the pain for a period of time, and you could kind of see if that kind of gets them out of the pain cycle and gets it so that you may not have to necessarily go CS. Hopefully not. That's my thoughts on that. Any other thoughts, Dr. Hackett?
Yeah, along those lines, Diana, I think something else to keep in mind is if you do end up giving a dose of Banamine to your colicky horse and he still or she still seems painful, don't follow up with another dose of Banamine, and certainly don't administer it more than every 12 hours for 1 or 2 doses. And the reason being is if you have a very serious colic, the Banamine isn't going to help the pain as much as it's going to result in the toxic side effects that Dr. Hassel was mentioning. So I would say definitely be careful if you're going to give it, and don't give another dose if they're still colicky. That just means they need more intensive pain medication and potentially some other life-saving medical intervention, like passing that nasogastric tube if their stomach's distended, or potentially getting them to a surgical center to really treat the primary problem.
All right, looks like we have one more question from Julie. What is the prognosis for returning to full work after colic surgery? That's a great question, and a lot of people will have that question if a horse comes in for surgery. And if your horse has surgery, undergoes surgery, and does okay post-operatively, is released from the hospital, they do have a good prognosis for returning to full work. Again, things can happen such as foundering if they have a real severe colic episode, so that could cause issues with lameness, obviously, and that may limit their ability to do work. If they got severe infections or hernias of their abdominal incision, that could influence it as well, but those are fairly rare. They don't occur all that often, and the vast majority of horses I'd say more than 90% for sure that go home from the hospital will be able to return to their original function, which is nice. The most common complication probably that has been reported in postoperative horses is having some recurrent, more mild colic episodes down the road. What's causing those is maybe, we're not sure, but could be adhesions, could be just the original problem. There's a tendency for gas buildup or tendency for impactions, that type of thing. So I believe that occurs in maybe 15 to 20% of our postoperative colic patients. So that would be the most common complication. But typically these horses can go back to full work in general. Any further comments, Dr. Hackett? Okay. All right. I think that's all for tonight. I hope you guys enjoyed the hangout with us tonight, and thank you for coming. If you want to see it again or you missed part of it, then you can watch this again at the CSU College of Veterinary Medicine and Biomedical Sciences YouTube page, or also the VTH Facebook page. There'll be access to this webinar, or if you want to tell your friends about it, just send them that way, and you can watch again. Thanks so much for coming. I appreciate you guys being here, and thanks for all the great questions. Bye.